So today we'll be presenting a video on the Biojet MRI TRUS fusion system, which we have been evaluating at UCL. As many of you will know, the pathway in prostate cancer diagnostics is changing to an MR pre-biopsy in order to find a lesion and improve the detection of clinically significant disease, improve risk stratification. MR TRUS fusion systems are necessary in order for the user to see the target so that they can get a greater yield of cancer and get a better representation of the disease. The dissemination of targeted biopsy requires MR to TRUS fusion in order for urologists in the general population to be able to deliver a targeted biopsy approach. The Biojet MRI TRUS fusion system has a number of characteristics which make it an attractive proposition. First of all, it's a rigid registration system and not non-rigid, but it has good accuracy. The system is transperineal or transrectal, and it can also give a real-time visualization of the needle biopsy and a record of where the biopsy has been taken. We're going to present a case study initially and then tell you about our program of evaluating this new technology. This is a 58-year-old man who's previously had a negative TRUS biopsy. This is a very large population, as many of you will appreciate. There are a number of men who have had numerous negative biopsies, and the random and systematic errors of the current transrectal biopsy that we conduct is responsible for a number of errors: missing disease, misclassifying disease, and finding unnecessary insignificant disease, who then get treated unnecessarily. This man has a PSA of 13.9, which is rising from previous PSA of 9. He had a multiparametric MRI, which included a 1.5 Tesla pelvic phased array coil with 2:2 weighted diffusion and dynamic contrast, and that showed a lesion in the left peripheral zone. The Biojet system involves uploading the MR images and contouring them on every slice in order to get a 3D model of the prostate. Here we demonstrate the contouring as it is done on the system on its own laptop. We initially contour the prostate. Here we're showing where the lesion is in the left peripheral zone. This is a T2 weighted image, and you can see the lesion as a low signal area. The rest of the peripheral zone has good high signal, and the BPH is heterogeneous on this particular view. The prostate is now being contoured, and this is fairly easy to do on the T2 weighted images. And each contour can be adjusted point by point in order to get a better correlation with the actual contour of the prostate. And again, just a few minor tweaks at the right posterolateral edge. We now move to the next slice and contour again. And you can place as many points as you like. The greater the number of points, the better the contour is, and therefore the better the registration. At the apex, it's more difficult to define the prostate. And as you can see on these images, all the other slices have already been contoured as well. For the sake of time, we've not shown these. We're now going to contour the lesion in red. And you contour what you can see on the T2. Obviously, the diffusion and dynamic images will have provided greater certainty that the lesion you're contouring on T2 is the lesion that you want to biopsy. Again, for the sake of time, we're not showing the evaluation of the multiparametric MRI, which clearly needs an expert radiologist to look through it. We then get a 3D reconstruction coronal in the bottom image and a 3D reconstructed image of the MRI of the sagittal. And those images we showed you are just running through the coronal and sagittal images, which are reconstructed. We're now going to set up the ultrasound probe. Here we're using a BK, and it's using the DK stepper. The BK probe needs a special collar in order to fit into the cradle of the stepper. We set up the prostate on transrectal ultrasound. A catheter has been placed, and we run through the prostate in the axial and the sagittal in order to make sure we're covering the whole prostate on ultrasound. We have then registered on the laptop. The laptop is monitoring the ultrasound images at the same time, and then we register the contoured MRI with its lesion onto the ultrasound images. And this is just showing you a rundown of the images through the axial planes. The registration system, as you can see, has a few millimeters of inaccuracy, but it conforms very nicely to the contours of the prostate generally. This is now a sagittal view. We're looking at the images on the laptop so that we can target using live ultrasound images. We place a cursor onto the lesion, and then the software tells us the best coordinate in which to place the biopsy needle. This can obviously be changed if there is deviation or errors that we need to cognitively take into account. Now we're going to demonstrate the third step, which is to take the actual targeted biopsies. The first of these will be MR to TRUS fusion biopsies using the Biojet system. The second of these will be cognitive targeted biopsies, where the operator decides where to place the biopsies. And then the third of this will be to take systematic transperineal mapping biopsies from the rest of the prostate. So the operator always has final say. Here you can see the needle, which is showing up brightly in the sagittal plane, and we've gone in through the coordinate that the software has told us to, and you can see that it's matching up nicely to the red area, which is the lesion that we have pre-contoured and now registered. And then now the needle is fired, and the software will record where the biopsy has been taken. We've gone in again, and we're taking another biopsy. And this shows you what movements are required at the patient end. Again, it's a fairly straightforward procedure when you have this type of setup in the transperineal route. Now we're taking cognitive images and cognitive targeted biopsies. What we mean by that is we've now switched off the registration system, and we're looking for where we think the lesion is based on the operator having previous knowledge of the MRI lesion. And you can see the operator pointing out where we think the lesion is, and we're going to take a biopsy from that area. So this is called cognitive registration. And the question we're asking at UCH particularly is whether a formal software registration-based system offers greater utility in terms of diagnostic yield compared to a MRI TRUS fusion system. In addition, at UCL, we take full sampling of the prostate, In this case, we zone the prostate biopsies into 20 zones, which is a modified system from Winston Barzell, who effectively invented this template mapping biopsy in Florida. And here you can see the histology report. The biopsies from all other zones were negative. There was some high-grade pin in zones 5, 13 and 6. And as you can see, there's 2 areas which were positive, and both of these areas are from the targeted biopsies. The fusion system showed Gleason 3+3 3 millimeters in one biopsy, and the cognitive biopsy showed Gleason 3+3 3 millimeters again in one biopsy. So here there was equivalence. As part of our ongoing prospective evaluation of this technology, we're going to take men with an MR visible lesion in their prostate and carry out the MRI TRUS fusion biopsy, which is the index test under evaluation, do the standard test, which in our practice is an MR cognitive biopsy, and then compare it to the reference test, which is modified Barzell zone sampling. This is a paired validating cohort study which will allow us to evaluate the utility of using MRI TRUS fusion against an accurate reference standard and compare it to the cognitive biopsy, which will also be compared to an accurate reference standard. Thank you for your attention.